Good afternoon, everyone. My name is Tu Huang. I work in the Mental Health Foundation Australia as a provisional counsellor and will be your host for this webinar today. I begin by acknowledging the Wurundjeri Woi people as the traditional custodians of the land on which I live and work, and pay my respects to them, their culture, their elders past and present. On behalf of the Mental Health Foundation Australia, I would like to welcome and thank you each of one of you for attending the Trauma and Eating Disorders. I would now like to invite our presenter, Dr. Suzy Redston. Before we start, I'd like to introduce Dr. Suzy Redston is a highly respected psychiatrist with over 18 years of clinical experience, specialized in the treatment of eating disorders and trauma-related mental health conditions. Her approach is rooted in compassion, collaboration, and clinical excellence. As a member of the Royal Australian and New Zealand College of Psychiatrists, Dr. Redston has played an active role in faculties of psychotherapy and adult psychiatry. She is also a committed member of both the Australian New Zealand Academy of Eating Disorders and the International Academy of Eating Disorders, reflecting her dedication to staying at the forefront of research and innovations in her field. Dr. Redston's treatment philosophy is holistic and patient-cared. She integrates psychological and medical interventions to create personalized care plan that address the root causes of mental illness. Her collaborative style empowers patients to take an active role in their recovery, and she works closely with multidisciplinary team to ensure comprehensive support. Dr. Suzy Redston is well regarded for her competence, compassion, and effectiveness as a psychiatrist. Her dedication to treating the whole person, alongside her commitment for ongoing professional development, ensures that her patients receive exceptional care for their psychological and medical needs. Please join me in welcoming Dr. Suzy Redston.
Okay, thank you. Have I got control now? Is that right?
Yes.
So I can, okay, thanks. I just have to view. Oh, how do I do share my screen again? I can't find the button. More. Oh, there it is. Sorry. Okay. And we're going to go from the beginning. Okay, so can you see my PowerPoint now? Excellent. So hi, I also acknowledge and respect the elders past, present and emerging of the Wurundjeri people of the Kulin Nation, who are the traditional owners of the land on which I live and work on. And as it says there, I'm a psychiatrist in private practice, and I really want to talk today about the important link between trauma and eating disorders. More than ever, it's crucial for us to understand this connection to provide effective support. I'll try and cover how complex the trauma response is, and how trauma can be cumulative, and that in one way of conceiving of an eating disorder is that it's a primary coping mechanism. It then becomes a problem in and of its own. Most importantly, I want to emphasise that these are treatable illnesses and full recovery is possible at any point in the illness. And the topics that we're going to talk about are quite personal and can sometimes be difficult to hear about. And so just take care. If anything I say makes you feel uncomfortable or worries you, most of these slides are based on research and my own experiences, and I've tried to tailor it so it shouldn't be too distressing. And remembering that the definition of eating disorder is really that I'm using is an overarching problem. I'll go into it a little bit more in later slides, but that eating disorders are serious mental illnesses that affect thoughts, feelings, and behaviours around food, body image, and self-worth. And it's very complicated because we biologically need to have a non-psychologically distressing approach to food and eating. But eating disorders are in no way about vanity, and trauma is not a one single dramatic event. It can be one single dramatic event, but most often it's a cumulative experience, and that trauma and eating disorders are complex and can affect anybody at any time. So I'm hoping by the end of today, you'll feel more informed and more confident supporting yourself or someone else who may be affected by an eating disorder. And write down any questions. I've got about 20 slides, but I'm also timing myself to give time for questions at the end. So just to sort of overarch the scope and impact of eating disorders. So point prevalence, 1 million Australians live with an eating disorder in any year. They can affect all ages, all genders, and all backgrounds. And they've got the highest mortality of any mental illness. Anorexia nervosa, if you break down the types of eating disorders, has the highest, but actually binge eating disorder, bulimia nervosa, they both have quite a high mortality as well. It's much harder to tease out the research around that. And so the types of eating disorders in general, there's anorexia nervosa, which most people know about, restriction of nutrition, fear of weight gain, distorted body image is the sort of the key characteristics. Bulimia nervosa, which is binging and compensatory behaviours to undo the binging. And classically, it's purging either by vomiting or abuse of laxatives or both. But people with bulimia nervosa can have other ways of trying to compensate for any food that they eat, the belief being that if you get rid of it, then there are no calories gained. Binge eating disorder is repeated episodes of binge eating that cause a lot of distress. The person, while they're eating, often feels out of control and feels very shamed and guilty afterwards. Binge eating disorder is not associated with overt compensatory behaviours, but quite a lot of people with binge eating disorder will decide to not eat the next day to make up for their binge, and then get hungry and hungry and hungrier as the day goes on, and then eat again. OSFED is other specified food and eating disorders, and basically it covers a myriad of types of abnormal approaches to food and eating, including what's termed atypical anorexia nervosa, which I hate that word because it's got atypical in. People who, it basically means people who have anorexia nervosa who aren't in this BMI category of under 18. BMI in and of itself is very problematic, and I have a whole soapbox about that, but I won't talk about that today. ARFID, which is avoidant restrictive food intake disorder. It's often about fears of choking, or very sensitive to certain textures or tastes or smells or colours, or somebody who just has no interest in food. So often this comes out in childhood. It can be part of another problem, like the classic is a child with autism spectrum who won't eat anything but white food, and they get very nutritionally deficient, and there's a very effective approach with the help of a dietitian, usually some family therapy work, and introducing slowly other foods. And there's also 2 other eating disorders, pica and rumination disorder, but I'm not going to talk about them today. But if you look this up, you'll see that they're referred to. So this slide's actually taken from the National Eating Disorder Coalition slide, and it includes all of the ones that you will find if you look it up in a categorical manual like Diagnostic Statistical Manual of Mental Illness or ICD, International Code of Diseases. So there's a wide spectrum. There's a lot of risk factors for eating disorders, and this is not all of them, but these are very common. So you get a person who may have a genetic predisposition. The family environment may be that, say, for example, the family are very into riding bikes. And so the family do lots of exercise regularly, and that's part of their family culture, which is fine. But then the child growing up in that family is bullied at school because they're short, and then gets a low self-esteem, and then they might start to put on weight, which happens just before you hit puberty. There's quite a lot of weight gain because your body's going to need that to help grow. And they go on a diet, and then they get a fear of fatness. And there's often lots of trauma, lots of regular traumas or a mixture of traumas in the person's background that they don't know how to express the feelings they have about these events, and the eating disorder serves to help that. So let's just do a quick potter through trauma. So trauma is, it's more than just a bad thing happened. It's a whole experience or a series of experiences that overwhelm our ability to cope. So something can be traumatic to a child that isn't traumatic to an adult. For example, anyone who's left a child, say at childcare for the first time, and sees their absolute distress at their primary caregiver leaving, that child is experiencing that loss as a trauma. But it gets repaired because the parent comes back, and then they're so thrilled and everything, and quite often they'll have a response of, "I'm so glad you're here," and then they'll hit their parent because they're angry too. And that is, but you have to have lots of these experiences, or a big single event, so a car accident, or being in a bushfire. Chronic trauma is where there's prolonged harm, like bullying, neglect, or domestic violence. Complex trauma, which can lead to complex PTSD, is where people have repeated trauma, often starts in childhood, and it often involves a primary caregiver who's a perpetrator of these traumas. And trauma can leave emotional marks. People can be anxious, hypervigilant, experience emotional numbing. They can mistrust themselves and others, and it can show up in the body in terms of having sleep problems, chronic pain, changes in appetite. And that's where you start to get this link between eating disorders and trauma. Now I'm just going to do how trauma can contribute to eating disorders. This study, Adverse Childhood Experience Study, was an excellent study done in the United States, where they looked at the backgrounds of people who are using health services. So it's a retrospective cohort study, but with thousands and thousands of people, and came up with these. These were a cluster of things, of 10 things that if you had these in your background, then you were more likely to ultimately use health services. And the hypothesis is that you have adverse childhood experiences which disrupt your neurodevelopment, which we know happens, and you get social and emotional and cognitive impairment, and then you're more likely to adopt health risk behaviours like smoking early, drinking early. You might eat a lot or not much. You might adopt behaviours where you do lots of risk taking, but you're more likely to do these multiple health risk behaviours leading to disease, disability and social problems, and then ultimately an early death, compared to people who don't have these in their background. So the impact of childhood trauma, and this is from this website, Child Trends, but is across all these domains. So the brain development, your cognition, your physical health, your emotional health, your relationships. In there, it's talking about attachment problems, difficulty forming relationships with peers. You're more likely to have depression, anxiety, post-traumatic stress disorder, negative self-image, low self-esteem. You're more likely to not be able to regulate your emotions. You might have poor impulse control. You might act out in harming ways like sexually or drugs and alcohol. You're more likely to have a teenage pregnancy if you're a woman. So it can affect all of these areas. And it's not linear, and it may not affect any of them. And you may have a whole lot of childhood trauma and be a very resilient person, because it's not, I'm not saying that correlation is causation, but the correlation was so strong with people who used health services that they did hypothesize a causation, and now they're looking at it the other way, and there does seem to be a causation. So how does it contribute to eating disorders? So emotional regulation, when emotions are overwhelming, controlling food can feel like controlling the internal chaos. So you're managing your feelings. So in anorexia nervosa, if you reduce your intake, you get, as a side effect, you become socially numbed. Emotionally numb, sorry. So that intense emotions that you don't know how to handle, like fear, anger, anxiety, depression, are now turned down. If you've got an overwhelming emotion and you can eat a lot, some people find that if they eat a large amount of food, it soothes them and makes them feel like the emotional state comes down. It can give a sense of safety. So some patients with anorexia nervosa will say, I remember one patient saying to me, I just wanted to disappear, and I thought if I was really, really small, I could disappear. But it can also give a sense of safety the other way. I've had patients with morbid obesity who feel very scared to lose weight because when they were thinner, they were sexually abused. It gives you if you focus on calories, weight, exercise, compensation, and restriction, overeating, or any of those things, then it distracts you from other psychologically painful experiences, and it can distract you from memories. And often after abuse, and especially childhood abuse, people feel a lot of shame, and they feel shamed by their body, or they try and change their body to avoid being hurt again. So it may be that they they go to a gym and they want to get very strong because they want to be able to fight back if they're ever attacked again. They get into this idea that they have to be very low percentage fat, and suddenly they've got no subcutaneous fat at all, which is actually not healthy. And suddenly they've got all this, and they're eating only protein, and they're only eating 3 times a day and doing a lot of exercise to get strong. And suddenly they've got an anorexia type picture, both biologically and psychologically. And trauma can plant seeds of self-hatred. And the eating disorder behaviours can be like, I deserve this punishment. And so the eating disorder in this way can be seen as a coping strategy, but they're not sustainable. They don't build internal resilience, but they can make sense for the person of what's happened in their life, or at least make it tolerable. And so this is it's a bit of a busy slide, but this guy, Dr. Brewerton, he's probably a professor now, but he's done a lot of work on trauma and eating disorders. And so looking at, there's a genetics and an epigenetic, which is epigenetics is how and when genes are expressed in cells in your body, and genetics is just the genes in your body. So that that can be affected by your epigenetics, definitely can be affected by trauma because they're affected by hormonal changes. Then there's social constructs. So, in the West for a long time, especially in the 90s and noughties, it was very fashionable to be bony and thin, and idealized that would make you lovable and happy. Then you put in the adverse childhood experiences, disrupted neurodevelopment for lots of complicated reasons, but the bottom line is that you need to be nurtured to have adequate neural development. And then you get problems with cognitive impairment or social and emotional impairment, or all three. Then you might adopt health risk behaviours like extreme dieting, binging, purging, substance use, self-harm, medical comorbidities, and so on and so forth. So some statistics that come out of a number of papers linking trauma and eating disorders, that up to 50% of people with eating disorders report trauma histories. And PTSD and complex PTSD are more common in the eating disorder population when compared to age-matched controls. And childhood abuse, neglect, and bullying are major risk factors for developing PTSD, complex PTSD, and eating disorders. So you can see straight away that there's this sort of intimate connection. And this doesn't mean, though, that trauma causes every eating disorder, but it's a major part of the puzzle. And for many years, doctors and psychiatrists and psychologists would say, I don't treat eating disorders, I only treat trauma, or vice versa. And we weren't trained well to ask and take good trauma histories from our patients. And often with the shame associated with having traumatic experiences, for example, a woman who is sexually assaulted will often feel ashamed that somehow she did something to make that happen, even though, of course, she didn't. So trauma can be a catalyst. It can precipitate an ED because when you're traumatized, you often feel powerless. Your self-perception's changed and your psychology's changed. Your psychological pain's high. And then the eating disorder helps you avoid the psychological pain and helps you with the emotional numbing. And of course, it affects your self-perception. So you feel betrayed by your body, or your body betrays you by getting fat or not getting fat. You feel shame, and shame is a very destructive emotion, because shame is, there is something bad with me. I am inherently bad, as opposed to guilt is I did a bad thing. So quite often I try and help people shift from shame to guilt, and then we can deal with the guilt by externalizing it and understanding what led to that behavior or not. And obviously it affects your self-perception, affects how you socially interact. And so that then affects how you build connections with other people. And humans have a desperate desire and need to have connections with others. And these eating disorders can impact that, and high load trauma loads can. So if we focus in for just a little while on anorexia nervosa, so that I can, it's where I've done a lot of work and a lot of reading and a lot of training. And I think that it's the one that has the highest mortality. And so I'm going to use that as the exemplar. So signs and symptoms of anorexia nervosa are restricted food intake. These days it's often whole food groups, so no fats, no carbohydrates, including, no fats, no carbohydrates. Dairy might be limited to very low fat content and high protein. At the moment, that's very trendy to get low fat, high protein yogurts that probably have actually very little true yogurt in them. The person develops an intense, overwhelming fear of weight gain. And they have a very distorted internal body image. So what they see is very different to what the reality is. So, for example, a person with anorexia nervosa will tell you, and they mean it, that they're really fat. And when you get them to sort of explore that, it'll be, oh, well, when I turn around and twist to the side, I get these rolls, of skin, is what it is. And that's fat. And it's like, well, actually it's not fat, but they perceive it as fat. And then they perceive that if you ask somebody with anorexia nervosa to line up a whole lot of different shaped and sized bodies, they'll do it really accurately. And then you say, put yourself in that list, and they'll always overcorrect. So they might put themselves 2 or 3 sizes bigger than they are. And then there's a lot of physical signs with anorexia nervosa associated with people wanting to and trying to. So their body is trying to conserve energy. So at a really overall level, we evolved over thousands and thousands of years before the last 500 years, where we, as humans, we had to survive feast and famine. So we have different expression of different genes in our way our body's metabolism can be affected with sustained poor nutrition, like we've got into a famine. And the effects of that are on the automatic nervous system. You get a very low heart rate, you get low blood pressure, your body starts, you can get osteoporosis because you're not eating and getting any calcium, phosphate, or magnesium in your diet, which the bones need. But phosphate, calcium, magnesium are really important at a cellular level for the cells to get energy. So what happens is you're not getting it in your diet, so the body takes it from the storage of calcium, magnesium, and phosphate, which is in the bones. And there's this push me, pull you kind of thing that happens across the whole body. In the bone marrow, which is where all our red cells and white cells and platelets come from, so all the components of our blood are generated in the red bone marrow, it's called, and that takes a lot of energy. And so what happens is, to try and conserve energy, the bone marrow gets less, the actual quantity of red bone marrow reduces and reduces, and that space is taken up with sort of a gluggish sort of fluid. So if you do a bone marrow biopsy on someone with severe anorexia, where you would normally expect to see cells, there won't be cells, or there'll be very few cells. You get problems. You can get problems with the liver that can't cope with. It needs certain. The liver is a very important organ, as you probably all know, and it's a powerhouse, and it needs more energy. So you start to get liver cells dying, which is a way of conserving energy to reduce the overall size of an organ. The brain is uses up most of our energy at rest, percentage-wise, and it's made up of a lot of fat. And if you're not having enough fats in your diet, you start to lose some of the volume of the brain. It does recover, but it also changes the way you think. You get very focused on food, and you get very focused on rules around how you eat food and what you do with food. And so what happens is that your thinking changes a lot, and it makes sense if you think about evolution, that if you're in a famine, you need to spend all day, every day, trying to source food for yourself and your tribe. And so it makes sense that the people that survived are the ones whose thinking changed. So there's also personality factors. People with anorexia nervosa specifically often have very high self-control and often have perfectionism. And we know that because most people can't stay on that kind of restricted diet for as long as people with anorexia nervosa. And I've already alluded to how trauma can be linked in, because people are trying to be smaller, or they feel like there's so much chaos in their life that this is their way to control it. So there's a feedback loop. So your disordered eating can make you feel, can ameliorate the feelings of shame, guilt, and distress, and the symptoms, which can be symptoms that precipitate disordered eating, and trauma-based symptoms like shame, withdrawal, and isolation can also be ameliorated by disordered eating. And I think so in anorexia nervosa, you get fear of weight gain, perfectionism, high self-control, trauma link, invisibility is safe. So you can see that they're all linked. You get a health decline, and then starvation, as I said, changes the brain, increased anxiety, rigidity. You can get depressed mood, or a mood that doesn't fluctuate. And then that makes it really hard to do any processing of trauma or any treatment of trauma. And so you get trapped, the person gets trapped within the eating disorder and the trauma sort of cycle. And that you have to you need to come up with a way of working with both to help them have enough resilience to cope with. So, for example, in anorexia nervosa, the first thing that happens when people start to eat normally in an emotional sense is they feel flooded by emotions they don't want to have. And so they immediately go, well, I'm going to restrict again because that felt so much better. So what you want to try and do is help them have other ways of coping with those flooded emotions. And often that's things like initially helping them with sensory emotional regulation. For example, if they're feeling angry, using ice to chew and make loud noises in their head can help with anger. But if they're feeling sad, it might be getting a really soft, lovely blanket and wrapping it around themselves and giving them a hug. And those sorts of techniques can help them learn that they can regulate their emotion without having to starve. And with other eating disorders, it's similar. So treatment and recovery. So I think you need to treat the trauma and the eating disorder together, or at least have a holistic approach. Understand that this person before you has these problems that are so intimately linked that they need to be considered together. Now, medical safety has to come first. So, for example, if somebody is medically so unwell that they need to be in hospital for medical recovery, which for somebody with anorexia is all of their fears at once. So if somebody is so unwell and they're refusing medical treatment, but they're going to die of starvation-related problems, so let's say they're down in the, I'm going to use the dreaded BMI, but let's say BMI is down in sort of 12 and they're hypothermic, so they're very cold, they've got a very low heart rate, very low blood pressure, they've got no white cells to fight infection. You need to feed them. The only treatment that's going to get them out of this is nutrition, but they're refusing because of their absolute fears. And so you end up making them an involuntary patient. They go into hospital, get fed against their will, usually by nasogastric feeding. It's really traumatic, and it's a double-edged sword because now you've added to their trauma, but they're alive now to deal with their trauma. So it's a horrible situation for everyone to be in. What you hope is that their eating disorder isn't that severe, so that you can work on both at the same time. And often you can. Now, the therapies that can help with both trauma and eating disorders include trauma-informed cognitive behaviour therapy, schema therapy, eye movement and desensitization and reprocessing therapy, dialectical behaviour therapy. There's a whole lot of specific other therapies that that have been developed for eating disorders and for trauma. There's cognitive processing therapy, and there's more. The bottom line is that if the person is connected to the therapist enough to build trust, then this type of therapy is not as important as that connection. And sometimes it's helpful to sort of do a staged approach. And depending on how long the eating disorder's been there and so on, it might take years to get to full recovery. But when people recover from eating disorders, they're often more resilient than their age-matched control. And if they have a family and they have connections in the community, having support from them is really, really important. And people talk about severe enduring anorexia nervosa or severe enduring eating disorders, and there's a helplessness with those sort of concepts. But actually, the evidence is that anytime somebody wants to start to change or is able to find a place to think about and consider change and let go of their eating disorder and its associated behaviours and focus on recovery, then they can recover fully. And it's one of the few serious mental illnesses that you do get people recovering fully from. And it's very satisfying, and it's lovely. I've got a patient at the moment who has had severe enduring anorexia nervosa for over 30 years. And we've been able to get her, we're able to get her well enough to do some very specific trauma work and go back and forth like that for about between trauma and eating disorder, improving all the time for about 2 years. And she's now let me know that she doesn't need to see me as often. And I am so thrilled for her. And I suspect I'll discharge her from my care after years next year. So how can you help if you've got anybody in your life who might be suffering from these problems? So when I say be safe, calm and non-judgmental, I mean psychologically safe. So don't say to somebody, oh, you look great in those jeans, so much better than last time I saw you. What they'll hear is, you think I'm fat and ugly, or you did then. Whether that, it doesn't matter what type of eating disorder they have. Try not to be judgmental. Try and see, not, I know culturally there's so much focus on weight and shape, and the medical fraternity itself is very stigmatized towards weight and shape and very gendered as well. And we're working on that, but it's going to take time. But I think trying to create a safe space for people where they know that, their body isn't the main reason that you're connecting with them. And that leads very nicely into avoid comments on body and food. So, don't say to somebody, like I had a patient with severe anorexia who there's this when you're recovering from anorexia nervosa, once your body comes out of this sort of hibernation stage, it goes into hypermetabolism to repair everything that's been donated to keep you alive. And so people need huge meal plans for it can be up to six months, but certainly at least 3 months. And they're more than anybody would eat if they didn't have the history of severe anorexia nervosa for over a year or more. And this poor patient, every time they got to that stage, their significant person would say, wow, that's a huge meal plan. And they would immediately start restricting it. So just don't comment. You're just not sure why they might be eating what they're eating. And certainly sort of encourage them, even if they bring it up, to say, let's not talk about that. Let's talk about something else. Encourage people to see someone early, GP, psychologist, psychiatrist. I know we're really hard to get into, so dietitian. There's some great services out there. And offer practical support. So things like helping them get to an appointment, sitting with them when they eat a meal, or just spending time with them where they can learn that it's okay to be with somebody without having to modify their behaviours. Your role isn't to fix them, but to help them feel less alone. That's what I mean about presence. It's a very isolating thing to have an eating disorder, because you can't say to somebody with an eating disorder, if you say to somebody with an eating disorder, hey, let's catch up, go to a movie on Friday night and go out for dinner afterwards, they might say, yeah, that would be great. And then for the rest of the week, they're preparing for and checking out, where are you going to eat? What am I going to have? How am I going to compensate for that? If I have that, can I have this? And it just takes over their whole mind. And they feel so isolated in all of that. So your role is to sort of, on that journey, you might say to somebody, if you know that they've got any kind of eating disorder, say, where would you like to go? Or do you want to just catch up for a movie and, we can not worry, we don't have to catch up for a meal. So various resources, okay? So Butterfly Foundation, that's their number. They have a hotline, but also their websites and all the drop-down menus and stuff are fantastic. Beyond Blue, and in keeping with Beyond Blue, there's also Headspace, has a lot of great resources online for people, and they have numbers you can call. And Headspace also has, it's really helpful for young people who are used to communicating by text and find telephone communication really hard. They have a whole texting sort of, I think it's part bot, part human, but I'm not sure. Lifeline also has an online version. And then local eating disorder services can be helpful. Eating Disorders Victoria, for example, that's the state I'm in, but each state has a different kind of service. And if somebody from Tasmania rings EDV, they're not, or links in with some of their online resources, that's fine. Like, no one's going to go, you can't. And not every state has the same kind of resources. In terms of trauma, which I should have put there, there's the Lighthouse organisation is very helpful. And then there's lots of information about post-traumatic stress disorder on Phoenix is a website, an Australian-based website that they do lots of research and training around for clinicians about how to help people with post-traumatic stress disorder and complex PTSD. But they also have clinical services. And then internationally, the Department of Defense in America has some great online resources for trauma. So my closing message is that eating disorders are not about vanity, okay? And trauma responses are not about weakness. They're human responses to overwhelming experiences, and we all have a different threshold. And with compassion, persistence, and the right support, recovery is possible, even after years of struggle. So that's the end of my slides, which should give us some time for question and answer. So I will stop sharing and hand over back to you.
Thank you, Dr. Suzy Redston, for presenting a very informative presentation on trauma and eating disorders. So we've got a bit of time for Q&A. Dr. Redston, would you like the question to be verbally asked or type them in the chat box?
I don't mind either. And the first one is, you can have this. So somebody said, is it possible to have access to the slides? Yep. I will give the slides to the organisation, and is that what you want me to do, or you just put up the
Yeah, we
recording?
will post this on the recording on YouTube.
Okay. But I don't mind sharing the slides. They're not like copyrighted or anything. Would that be, I just don't know how to do it. Like, do you want me to put it in the chat?
Or yeah, you can put in the chat and people can have access to that in that way. Yeah.
All right, that's
Thank
fine.
you.
That's all right.
So if anyone have any question, can you please type in the chat box and I will read it out once we have it.
Oh, maybe I left too long for questions. Sorry. Last time I did this talk, we went over time. There's references in the PowerPoint too, if people want to look up different things.
Raise your hand.
Oh, okay, sorry. Someone said the chat was disabled. I think it's fixed now. So
okay.
we might have
that makes sense.
Yeah.
Okay. So now is it sorry. Okay, is it abled now?
Someone said chat is disabled.
Yes,
Perhaps
the Q&A is enabled. If anyone has any questions, you can either use your Q&A at the bottom of the screen or the chat function.
Oh, okay. So in children, how do early relational traumas, particularly attachment disruptions or experience of emotional neglect, influence development, restrictive or compulsive? Okay. Okay. So that's a big one, but there are markers we should watch for to differentiate trauma-driven patterns from other presentations. So the thing is that attachment disruptions can be at the root of any mental illness, and and attachment disruptions can make people vulnerable to mental illness. But what can happen is that internally it makes your sense of self very fragile. And so what can happen is that a person starts to identify that they're a more worthwhile person if they control their food and eating, or if they they feel they can soothe themselves with food and eating, but then feel bad about it and might compensate, which is more the bulimia picture. So what you can't differentiate trauma different patterns from other presentations per se, but parents just have to be good enough. It's not about perfection. And emotional neglect is when it's pervasive, and the most common as in no one ever helps you identify your emotions when you're pre-verbal, when you're able to talk, no one allows you to have your own emotions or doesn't tell you how to cope with them. I haven't posted them in the chat yet because I'm answering the question. Okay, I'll do it in a sec. And so that if somebody's got pervasive attachment disruptions or emotional neglect, and you see that their behavior is changing in terms of either to food or to exercise or they're becoming secretive, or the single biggest risk factor is to go on a diet. And what I see is people who they've got very demanding parents who want them to be very good and want them to achieve. And then let's say, for example, the person feels like they're only valued if they're really good at something, and then they go on a diet. And so now they have to be the best at a diet ever. And then they can then develop anorexia nervosa.
We have another question.
Yeah, I'm just closing one window and okay.
I can read it out.
I can see that now. Is it considered an eating disorder if the eating pattern is affected by interoception? So hyperfocus and not attending to your basic needs like food and eating is the intervention for that is actually around skills development. And it's partly interoception, but if they're ASDs level 1 or 2, then they will have an interoceptive experience, and it's about helping them understand that and acknowledge it. And that's about using OTs and psychologists to help them learn that. And then they can internalize it by learning it. In severe ASD, so level 3, you have to just do it for them. You have to just say you need to eat this or drink this now, because they can't do that. So it's not considered an eating disorder in the same way, because they don't actually have they don't have any fear around food and eating. They just don't have any, they just don't think about it. Whereas people with eating disorders are thinking about food and eating all the time. They're completely distracted by it. Is borderline personality disorder and other antisocial coercive controls now a criminal offence because they have to do? Do you find this is used as form manipulation? So we talk about cluster B personalities, which includes borderline personality, histrionic personality, antisocial personality. They're all got similar features in that the person with that disorder lacks empathy for the other. And if you're in a relationship with somebody with one of these problems, narcissistic personalities in there too. And most people will have bits of each. So making something a criminal offence will not change how it is experienced by the person who's subjected to it. And what can happen in relationships that maintain or cause eating disorders. And the one I've seen a lot of, and I admit I see anorexia nervosa is the main eating disorder I see, is people who make their love contingent on somebody's body being a certain weight and size. So, oh my God, you're so fat and ugly, I can't possibly love you. Oh, but I love you if you go on this diet. And it is a form of coercive control, but it's, as you probably know, people who I don't think there's an epidemic of family and domestic violence. I think finally it's being acknowledged to the level that it's been occurring for hundreds of years. I haven't put the slides up. I keep meaning to. I'll do it at the end. I work with paediatric and have a concern that the medical treatment. Oh, so at the moment, and there's a professor of eating disorders called Stephen Toys, who is in Sydney, and he and I had a bonding over this recently. But so the treatment that's imposed upon all paediatric patients with eating disorders is family-based treatment, and it's not therapy. It's basically making the families the police people to make sure the children eat food and have enough food, and it causes so much trauma to most families. It doesn't work in most families, and it causes a lot of trauma to the family dynamics and to each relationship in the family. Just like me making somebody involuntary to feed them up to get them well enough to tell me what a horrible person I am is a huge trauma. So basically, I think the best way to emotionally support a medically unstable pediatric eating disorder patient, if the only place we have is hospitals, and people get very scared of the medical complications of starvation, because at any point, if they're really profound, the person might need high level of care within minutes. So having specific eating disorder services that don't have medical backup is very, they have to be well enough to be in them. So often what I recommend is trying to separate for the child and their family, the team into the person who is it's usually the doctor. They're the baddie, they're the bad parent. They're going to make sure this person eats even though they don't want to eat, and they're going to do whatever they need to do to get them medically well enough to get out of hospital. And then the psychologist or the nurses, and the nurses get caught up in being the bad because they have to implement things if the child needs nasogastric feeding. But you want to have some identified people on the team, or the team around the child and the family, that can be the good ones, who can help soothe, can help validate that this is terrifying and scary and horrible, and keep reiterating that this is to get you well enough so you can sack them. This is to get you well enough so you can come back and tell Suzy what a dickhead she is. And if you use that kind of collaborative, us against them at that stage, it can be helpful, because they feel like they feel so alone, these children. And I've worked in pediatrics a lot. So, and then I work with adults who've got lots of trauma from their pediatric experiences. And it's if we can get them treatment earlier, that would be better. And I think all the education of GPs is helping that. So, and the conversation, it's now not so shameful to talk about eating disorders.
We have another 2 questions in the Q&A.
Okay.
Yeah.
Yep. Sorry.
Thanks. I'll read it out for you.
Yep.
So I'm wondering how you approach a person who is experiencing an eating disorder sensitively to encourage them to seek help without resorting to involuntary admission. Also, how do you recover from the rupture or distrust after the involuntary admission? Trauma re-triggered.
Okay, so the first part is that it depends how physically unwell they are and how much space and time they've got. So I usually start with the analogy that we're not plants, so we can't photosynthesize to make our own energy, and they need energy to make that, to help them go from starvation mode that their body's in to, if it's a starvation one, to the into normal mode, normal metabolism. And that if so you want to encourage them to get to talk to someone before they get to the point where they need an involuntary admission. Now, COVID-19 pandemic brought out the fact that lots of people, we got a 300% increase in presentations of people under 26 with medically unstable eating disorders during that period of time. So social isolation, big problem in people who develop eating disorders. So sometimes getting them to have a look on the internet on like Eating Disorders Victoria, getting them to ring up. They have a peer support line, or they can have, there's all different sort of peer support things that can be helpful, where a peer says, oh yeah, look, I did that and then this ended up happening to me. I recommend you try this first. And sometimes you have to collaborate with the eating disorder a bit and say, look, we just want to get you medically stable, and that might mean we have to hold you at a weight or a meal plan that your natural body, as in not dieting, not following a meal plan, just living your best life, won't be happy at, but we'll be able to give you therapy and work through it and see if we can get you to a different space. And so it's sort of a staged approach is often what's most helpful. And how do you recover from rupture distrust? So I always tell people if I make them involuntary, and I haven't done it for over a year now, which is probably quite good. I say, I'm doing this because I care enough to threaten our relationship to have you come back and tell me you hate me, or have your anorexia come back and tell me how awful that was. And then I hold that with them. Now, sometimes, yeah, sure, they say, I don't ever want to see Suzy again, she's horrible. But in the process, I've also communicated with their GP, their dietitian, their psychologist, who can all hold that memory with them, that, you know, that actually it was done because nothing else was actually helping, and you were getting to the point where you were very in danger. With adolescents and children, the trouble is that if they maintain the starvation too long, their growth in every part of their body gets, I'm going to use the word retarded because I can't think of a better word, but it gets held back, and that can be very dangerous for their life. For adolescents, what's the effective treatment approach? There's no one treatment approach for any eating disorder, doesn't matter what type. And guidelines keep changing. The best thing to think about, what I would say is if the treatment, because in public you don't get a lot of choice, if you get offered family-based treatment and it's not you haven't moved from phase 1 to phase 2 within 8 to 12 weeks, then it's not going to work in your family, and you need to think of something different. Or you and the team need to get together and think about something different. And sometimes it's about treating the adolescent separate to the family and getting a family therapist and adolescent therapist. There's lots of ways to do it. I think I've answered all the questions. Have I answered all the questions? There's things in chat and there's things in Q&A. It gets very confusing.
Yeah, I think we missed one last question.
Yep.
In children, how do early rational traumas, particularly attachment disruptions or experiences of emotional neglect, influence the development of restrictive or compulsive eating
I tried to answer that before. So
right,
around how it's complicated and that it depends on the culture and so if you have relational traumas, attachment disruptions, emotional neglect, you're very likely to develop some kind of mental illness depending on the family culture, the culture they're living in, and the age when things start to unravel in their psyche, then that will determine whether they get a personality disorder, an eating disorder, a major depressive disorder, with self-harming. It'll depend on other factors. And I don't think there are any particular markers. If there were, my God, I'd be so famous. But I don't think there are. Okay.
All right. Thank you, Dr. Suzy Redston, for answering questions from our audience and your excellent presentation. Now, I'd like to take a moment to thank each and every one of you for joining us on our today's highly informative webinar on trauma and eating disorders.